Cornea. Coming to anatomy. Now anterior surface of cornea is elliptical, horizontal diameter approximately being 11.7 mm and average vertical diameter being 11 mm. Posterior surface is circular, average diameter being 11.5 mm. Thickness of cornea in the center it is 0.5 to 0.6 mm. Periphery it is more thicker, periphery it is around 1.2 mm. Radius of curvature anterior it is 7.8 mm and posterior it is 6.5 mm. Refractive index is 1.376, refractive power is approximately 45 diopter, that is 3/4 of the total refractive power of eye. Histologically there is 5 distinct layer of cornea. First one is epithelium. Epithelium it is stratified squamous type. The deepest layer, the deepest basal layer, this is the basal cells, these are columnar cell. This is epithelium of cornea, basal, deepest is a basal cell, these are columnar cell. Next 2 to 3 layers are the umbrella shaped cells, umbrella shaped, and the most superficial cells are the flattened cells. Superficial cells are the flattened cells, the flattened cells. Okay, then come next is the Bowman's membrane. Bowman's membrane it is actually a condensed collagen fibril, condensed collagen fibrils. It is an acellular mass of condensed collagen fibrils. It is 12 micrometer in thickness. It is a condensed part of superficial stroma. Shows considerable resistance to infection. This if Bowman's membrane is once destroyed, it cannot regenerate. It cannot regenerate. Next is stroma or the substantia propria. Substantia propria. Its thickness is around 0.5 mm. That is 90% of the corneal thickness. Collagen, it contains the collagen fibrils type 1, 5 and 6, which is embedded in the hydrated matrix of proteoglycan, that is chondroitin sulfate. It is embedded in hydrated matrix of proteoglycans, that is chondroitin sulfate and keratin sulfate. These are the proteoglycans, chondroitin, keratin sulfate. Then there are keratocytes also in corneal stroma. Keratocytes, that is fibroblasts are present, macrophages are present, histiocytes, leukocytes are present in the lamella. Descendants membrane is a posterior elastic lamina. Posterior elastic lamina. It is a homogeneous membrane of cornea. This is a descendants membrane. It is a homogeneous membrane of the cornea and shows considerable resistance to chemical agents, trauma and pathological process. It contains collagen and proteoglycans. It can regenerate. It can regenerate as it at its periphery it appears to end at the anterior limit of trabecular meshwork, that is the Schwalbe's line. Peripheral termination that we have discussed it in glaucoma. Then next is endothelium. Endothelium it is a single layer of flat polygonal epithelial cell. It is misnamed. It is actually misnamed as endothelium. It's the flat polygonal epithelial cells. Okay. Average cell density is 2800 to 3000 cells per millimeter cube. Cell density decreases with age. Cell loss with age is compensated by its enlargement known as polymegathism. Corneal decompensation occurs after 75% of cells are lost, then corneal decompensation occurs. At a density of about 500 cells per millimeter square, corneal edema develops and transparency is impaired. Now, corneal transparency is a result of the peculiar arrangement of the corneal lamellae. The peculiar arrangement of the corneal lamellae, that is the corneal theory of Morris, lattice theory of Morris. Then also because of avascularity, relative dehydration, dehydration, 78% water content is there, and swelling pressure of the stroma. Swelling pressure of the stroma, which counters the imbibition or effect of IOP. Because of the swelling pressure of the stroma, it counters the imbibition pressure of IOP. These are the factors which maintain the corneal transparency. Coming to congenital anomalies in cornea, there can be megalocornea. Megalocornea is normal horizontal diameter at birth is 10 mm. Adult size is 11.7, which is attained by 2 years. When horizontal diameter is more than 11.7 millimeter at birth, if it is more than 11.7 mm, or at 2 years if it is more than 13 mm, then we say it as megalocornea. Next is microcornea, that is when the horizontal diameter is less than 10 mm since birth. It is rarely associated with nano-ophthalmos. Nano-ophthalmos is normal small eyeball, or micro-ophthalmos. Micro-ophthalmos abnormal small eyeball. Now coming to bacterial corneal ulcer. Bacterial corneal ulcer. Now bacteria that can invade intact epithelium are Neisseria gonorrhea, Neisseria meningitis, Corneabacterium diphtheria. Symptoms of bacterial corneal ulcer include pain, foreign body sensation, watering, photophobia, redness. Signs include swelling of lids. We will start from lids, swelling of lids, blepharospasm, bacterial corneal ulcer. Coming to hypopyon corneal ulcer. Hypopyon corneal ulcer, characteristic hypopyon corneal ulcer is produced by pneumococcus, that is Ulcus serpens. So known as Ulcus serpens. Now predisposing factors for development of hypopyon is high virulence of the organism or low resistance of the tissue. Bacterial toxins. These bacterial toxins produce iritis, which lead to outpouring of leukocytes from vessels that gravitate to the bottom of anterior chamber. That is why hypopyon is sterile, because it is due to bacterial toxins and not due to bacterial invasion. Okay. Hypopyon remains sterile as long as the Descemet's membrane is intact. Now there is reverse hypopyon. This is the reverse hypopyon here. It forms when the emulsified silicone oil which is used during vitreoretinal surgery enters the anterior chamber of the eye. Complications of corneal ulcer include toxic iridocyclitis, or secondary inflammatory glaucoma. Secondary inflammatory glaucoma, that is fibrous exudates can block the anterior chamber angle. Secondary inflammatory glaucoma can be there. Inflammatory glaucoma, or decimetocele or keratocele can be present. So keratocele. Perforation. The perforation can cause iris prolapse. Perforation, if it all happens, then there can be iris prolapse. There can be subluxation or anterior dislocation of lens. Anterior capsular cataract can occur. Corneal fistula can occur. Corneal fistula. Purulent uveitis. Endophthalmitis. Intraocular hemorrhage. Corneal scarring. Treatment of, these are the complications. Treatment of uncomplicated corneal ulcer include topical antibiotics, Topical antibiotics can be given. Cycloplegic drugs like atropine. Analgesics, anti-inflammatory and anti-inflammatory. Hot fomentation and dark goggles can be given. For non-healing corneal ulcer, the causes, there can be a lot of causes, like local causes can be increased IOP or concretions, misdirected cilia, dacrocystitis or lag of thalamus, vascularization. These are the causes for non-healing ulcer. Local causes, systemic causes can be diabetes mellitus, malnutrition, chronic disease, steroids, systemic steroids, severe anemia can also causes non-healing systemic can lead to non-healing corneal ulcer. Treatment basically involves removal of the associated cause. Whatever it is, treat the underlying cause, then we can do debridement of the ulcer to remove the necrosed material. Cauterization can be done in case of unresponsive cases, but it is rarely done now. Then bandage, contact lenses can be given. Peritomy is done. Peritomy can be done. It is severing of the perilimbal conjunctival vessel. These vessels will be there. It is severing of the, when we do peritomy, their perilimbal conjunctival vessels are severed, and when excessive corneal vascularization hinders healing, we do peritomy. Best treatment for a perforated corneal ulcer is therapeutic keratoplasty. For perforated, okay, perforated corneal ulcer is therapeutic keratoplasty. Now, treatment of impending perforation. If there is impending perforation, then we should ask the patient to not strain to the eye, like no coughing, no bending down like that. Then pressure bandage can be given. Then IOP should be lowered, lowering IOP. Tissue adhesive glue like cyanoacrylate. Then bandage contact lens, soft contact lenses can be given. Amniotic membrane transplantation. Penetrating keratoplasty, tectonic graft can be given, can be done. That is bacterial corneal ulcer. Now coming to herpes simplex keratitis. Herpes can be primary herpes or recurrent herpes. In primary herpes, the symptoms are less compared to recurrent. Like primary, there is acute follicular conjunctivitis or fine epithelial punctate keratitis, coarse epithelial punctate keratitis, or dendritic ulcer can be seen with terminal knobs. There will be this dendritic ulcer with terminal knobs will be seen. If the without terminal knobs is seen, then it is usually seen in herpes zoster. In herpes simplex, these terminal knobs will be seen. These knobs here will be seen. In recurrent herpes, it is characterized by epithelial keratitis is characterized by corneal hyposthesia, then punctate epithelial keratitis, dendritic ulcer, geographic ulcer and geographic ulcer. This is a dendritic ulcer here. These are the superficial punctate keratitis. These dots on fluorescent staining, we can see these punctate erosions in the cornea. And these are the this is the geographic ulcer. The geographic ulcer can be seen. Then coming to stromal keratitis, there can be deciform keratitis. Deciform keratitis or diffuse stromal necrotic keratitis can be seen. This is a deciform keratitis here. Deciform keratitis. Then it can in recurrent herpes there can be trophic keratitis, or herpetic iridocyclitis. These are seen in recurrent herpes. Recurrent herpes. These are seen in primary herpes, follicular conjunctivitis, fine epithelial punctate keratitis. Deciform keratitis. Deciform keratitis is nothing but a focal disc shaped patch of stromal edema, the focal disc shaped patch of stromal edema without necrosis, usually with an intact epithelium. That is folds in Descemet's membrane, can be seen here, intact epithelium. Keratic precipitates can be seen. A ring of stromal infiltrate, known as a Wesley's immune ring. Ring of stromal infiltrate can be seen. Treatment in epithelial keratitis. Epithelial keratitis, we give topical antiviral. That is acyclovir is a drug of choice. Acyclovir. Steroids shouldn't be given in epithelial keratitis. Stromal we give topical antiviral plus steroids, plus topical steroid. In epithelial keratitis, steroids are contraindicated. Then metaherpetic keratitis, we usually give in metaherpetic keratitis, we can give, that is a trophic ulcer. Metaherpetic trophic ulcer, also known as a metaherpetic keratitis. We can give artificial tears like methylcellulose or hypomethylcellulose, and soft contact lens, BCL, and lid closure can be done. This trophic keratitis. This pseudodendrites is usually seen in herpes zoster ophthalmicus. Pseudodendritis can be seen in acanthamoeba and fungal corneal ulcer. Next, coming to herpes zoster ophthalmicus, it is acute infection of the Gasserian ganglion by the varicella zoster virus. Virus travels down through one or more branches of the ophthalmic division of trigeminal nerve. See the frontal nerve. Frontal nerve is the frontal nerve. That is branches of frontal nerve, that is the supraorbital and the supratrochlear nerve and the infratrochlear nerve. Branches of the infratrochlear is branches of the nasociliary nerve are always involved. These are the nerves which are commonly involved. Infraorbital is rarely involved. The frontal nerve, supratrochlear, supraorbital, and infratrochlear branches are rarely are usually involved. Infratrochlear, the infraorbital nerve is infraorbital, rarely involved, and lesions are strictly limited to one side of midline of the head. Next, coming to Hutchinson's rule. Here the oculi involvement, according to this rule, the oculi involvement will be is frequent if the side of the oculi involvement will be frequent if the side or tip of the nose, side or tip of the nose presents with vesicles due to involvement of the nasociliary nerve. That is Hutchinson's rule. Now skin of eyelid, this eyelid skin becomes red and edematous. Red and edematous eyelid skin. Then the patient will have microdendritic epithelial ulcer. Microdendritic epithelial ulcer. That is, it is peripheral and stellate shaped in herpes zoster. Then there will be pseudodendrites. They are typically smaller than typical dendrites. They are smaller and lack terminal bulb. The terminal bulb is not there. Here this is a herpes simplex where you have this terminal buds, and this is a herpes zoster. It is smaller and they don't have this typical terminal bulb. These bulbs are absent in herpes zoster. Then the patient will also have anterior stromal nummular keratitis. Anterior stromal nummular keratitis. Then there is deciform. Patient can have manifest with deciform keratitis. This deciform keratitis is always preceded by nummular keratitis. Then mucus plaque keratitis it usually develops between 3rd and 5th month. Then patient can have episcleritis, scleritis, iridocyclitis, acute retinal necrosis, etc. This is the picture showing nummular keratitis. Then corneal sensation is typically seen in herpes simplex or herpes zoster virus infection. Okay. Now next coming to mycotic corneal ulcer. Mycotic corneal ulcer, most common causes as per Gillis. Then mode of injection is injury by vegetative matter, that is crop, leaf, branch of a tree, straw, hay, etc. Injury by animal tail can also be, patient can also give history by injury by animal tail. Symptoms is similar to bacteria but it is less marked in fungal. Signs is out of proportion. Symptoms is less marked but signs is out of proportion to symptoms. Signs include dry looking. The bacterial ulcer is more wet looking. This is a dry looking ulcer with elevated, rolled out margins. The patient will have feathery extensions into the surrounding retina, into the surrounding stroma. Feathery like extensions into the surrounding stroma. Then the patient will have a sterile immune ring, that is a yellow line of demarcation. Sterile immune ring, that is a yellow line of demarcation. And small satellite lesions will be there, and a big hypopyon will be present. Big hypopyon, small satellite lesion, and sterile immune ring will be present. Big hypopyon is not sterile. Hypopyon is often not sterile, that is known as pseudo hypopyon. It is not sterile. Perforation is rare and corneal vascularization is also absent in case of mycotic ulcer. Next is acanthamoeba keratitis. In acanthamoeba keratitis, it is acanthamoeba castellani is the most common cause. It does not require a human host to complete the life cycle, hence it is known as a free living amoeba. It is usually seen in contact lens wearers using homemade saline. Homemade saline is the most common cause in the developed countries. Trauma with contaminated vegetable matter. Contaminated vegetable matter is the most common cause in developing country. Contact lens wear is the most common cause in developed countries, and trauma with vegetable matter, contact with contaminated vegetable matter is the most common cause in developing countries. Other causes include exposure to contaminated water, especially fresh water source, then swimming pools or hot tubs, etc. Now, it is an opportunistic infection in herpes, herpetic, bacterial, and neuroparalytic keratitis. And bullous keratopathy. It is common in immune compromised and debilitated persons, which may result in granulomatous amoebic encephalitis. Here in this acanthamoeba keratitis, pain is out of proportion to signs. Now coming to signs include limbitis, limbal inflammation, radial keratoneuritis, that is radial perineuritis, epitheliopathy, can be punctate or irregular epitheliopathy. There can be epithelial ridges, pseudodendrites or true dendrites can be seen. Infiltrates can be seen. It can be patchy stromal, satellite, central or paracentral. Ring infiltrates can be seen. Then ring abscess can be seen. This is the ring infiltrate here. This is ring infiltrate, and here we can see the punctate epitheliopathies or epithelial ridges. Corneal scrapings are helpful. In corneal scrapings, confocal microscopy, we can see the visualization of cyst is possible. There is a confocal microscopy. Here cyst can be seen. Then KOH mount, calcofluor white stain, lactophenol cotton blue stained film can be used. Then culture in non-nutrient agar, that is E. coli enriched non-nutrient agar is a culture is done in this. Okay, this you should remember, non-nutrient agar, E. coli enriched non-nutrient agar. Treatment is propamidine isothiionate and polyhexamethylene biguanide eye drops. Polyhexamethylene biguanide eye drops. Next is chronic serpiginous ulcer. Chronic serpiginous ulcer, it is also known as synonyms of Moran's ulcer or rodent ulcer. It is a degenerative superficial staining at the corneal margin, and it spreads circumferentially. It starts at the corneal margin and spreads circumferentially. Causes autoimmunity, and peripheral ulcer is associated with undermining edges. That is a characteristic. Okay, undermining of the epithelium will be seen. Characteristic whitish overhanging edge will be seen. Characteristic is whitish overhanging edges, as here. Whitish overhanging edges will be seen. It rarely perforates. Okay, perforation is very rare. Now next, coming to Theigson's superficial punctate keratitis. The etiology here can be viral or allergic. There is no conjunctivitis. Patient doesn't have conjunctivitis symptom, and bilateral punctate epithelial erosions, that is snowflake erosion, situated in the pupillary area of the cornea is seen. These are the bilateral punctate epithelial erosions situated, that is snowflake erosion situated in the pupillary area of cornea is seen. It is of long duration. There will be course of remission and exacerbation in between. Long duration will be seen. Healing without significant scarring is there. Healing without significant scarring. No clinical response to antibiotics. Okay, no response to antibiotics in these patients, and striking symptomatic and clinical response to corticosteroids will be seen. No clinical response to antibiotics, topical antibiotics, but striking symptomatic and clinical response to topical corticosteroids will be seen. Next is interstitial keratitis. In interstitial keratitis, here there is inflammation of the corneal stroma. The stroma without primary inflammation of epithelium or endothelium. There is syphilitic lutic interstitial keratitis. Syphilitic lutic interstitial keratitis. It is associated, the 90% of cases is associated with congenital syphilis. It is usually bilateral in congenital syphilis and unilateral in acquired syphilis. Okay, usually. Now there is something called Hutchinson's triad. It constitutes, in congenital syphilis there is Hutchinson's teeth, vestibular deafness, and interstitial keratitis. It is initially progressive phases seen with keratic precipitates, ground glass appearance of cornea. Then there is florid stage. It is characterized by deep vascularization of cornea. Deep vascularization of cornea and salmon patch appearance of cornea is seen. Stage of regression is there. Next is stage of regression. Initial progressive phase, then florid stage, then stage of regression. In stage of regression, we see ghost vessels in cornea. Okay. Now next, coming to exposure keratopathy. In exposure keratopathy, eyes are covered insufficiently by the lids, and there is loss of protective mechanism of blinking. Causes include extreme proptosis, Bell's palsy, or any other cause of facial palsy, ectropion, simpliferum, and deep coma can be the causes. Next, coming to bullous keratopathy. Bullous keratopathy is sometimes incorrectly called secondary Fuchs dystrophy. Sometimes it is incorrectly called as secondary Fuchs dystrophy due to corneal endothelial damage. It is due to corneal endothelial damage. Causes most common is after complicated cataract surgery. Endothelial cell density of 500 cells per millimeter square is required minimum to maintain transparency of the normal cornea. Normally this much is required. Normally 500 cells per millimeter square is required to maintain normal transparency of the cornea. Average loss of cells after routine cataract surgery is 2 to 10%. Average loss of cell after routine cataract surgery is 2 to 10%. Whereas following complicated cataract surgery, it is about 16 to 20%. Now measure to minimize cell damage. Cell damage. Measures to minimize cell damage include adequate anesthesia, hypotension, use of good quality viscoelastic and physiological solutions can be used like ringer lactate or balanced salt solution. Treatment is application of bandage contact lens and frequent instillation of concentrated sodium chloride saline solution. Okay, 5% sodium chloride can be given. In severe cases, optical or penetrating keratoplasty is the treatment of choice. Next, coming to crystalline keratopathy. It is a condition in which the crystals are deposited in the corneal epithelium or anterior stroma. In infectious crystallopathy, infectious causes there or can be associated with corneal dystrophies. Infectious crystalline keratopathy, Streptococcus viridans. Streptococcus viridans is the most common organism. Now, corneal dystrophy is associated with crystal deposits in cornea. Corneal dystrophies can be associated with crystal deposits in cornea, include Schneider crystalline corneal dystrophy or Bitty crystalline corneal retinal dystrophy or primary or secondary lipid keratopathy. Medication induced can also be seen. Crystalline keratopathy medication is topical fluoroquinolone. Or metabolic disorders like cystinosis, dysproteinemia, hyperuricemia, multiple myeloma, porphyria. This can be associated with deposition of crystalline keratopathy. This is a picture showing crystalline keratopathy. You can see a crystalline deposition in the cornea. It can be either infectious or corneal dystrophies, medication induced, metabolic. Next is vortex keratopathy. Vortex keratopathy is also known as cornea verticillata. These are fine golden brown. See here you can see fine golden brown opacities which form an irregular horizontal line in the lower corneal epithelium of both eyes. There are several irregular branching horizontal lines forming a pattern resembling the whiskers of a cat. Causes can include amiodarone, chloroquine and hydroxychloroquine and Fabry's disease. That is vortex keratopathy. Next, coming to photophthalmia. Photophthalmia is multiple erosions due to effect of UV rays. See, we have multiple erosions can be seen due to effect of UV rays, especially from 311 to 290 micrometers. Now, causes include exposure to bright light of a short circuit, or due to naked arc light exposure as in industrial welding and cinema operators. Naked arc light as in industrial welding and cinema operators, or snow blindness due to reflected UV rays from snow surface, snow blindness. There is a latent period of 4 to 5 hours between exposure and onset of symptoms. Latent period of 4 to 5 hours between exposure and onset of symptoms. Now, burning pain with pricking sensation, that is sandy eye. Burning pain with pricking sensation. Then other causes like lacrimation, photophobia, blepharospasm can be seen. Prophylaxis is Crooker's glass which cuts off UV rays and infrared rays. Next, coming to age-related corneal degeneration. It can be, there are few types: Voges white limbal girdle, Arcus senilis and Hassel-Henle bodies. Voges limbal girdle, it is a bilateral chalky white opacities in interpalpable area both nasally and temporally. Opacity is at the level of Bowman's membrane, that is Voges white limbal girdle. Next is Arcus senilis. It is an annular lipid infiltration of corneal periphery. Here that is arcus senilis. 60% of prevalence in the age group of 40 to 60 years can be seen. 100% prevalence if more than 80 years. It starts in the superior and then goes to the inferior quadrant. A ring of opacity, here a ring of opacity separated from the limbus by a clear zone. That clear zone is known as lucid interval of Vogt. That is ring of opacity is separated from limbus. By a clear zone, that is known as lucid interval of Vogt. Next is Hassel-Henle body. It is the most common senile change in cornea. There are most common senile change in cornea. There are these excretion, drop-like excretions of hyaline material projecting into AC around the cornea periphery. It arises from the Descemet's membrane. Here, these are the Hassel-Henle bodies. It can become larger and invade central cornea. Then it is known as cornea guttata. These are the age-related corneal degenerations. Next, coming to pathological corneal degenerations. It can be calcific degeneration, that is band-shaped keratopathy. There is deposition of calcium salts in the Bowman's membrane. That is a more superficial part of Bowman's membrane, and then superficial part of stroma and deeper layer of epithelium. Now here this is a picture showing band-shaped keratopathy. In children, band-shape may be presenting sign of chronic uveitis as a result of juvenile idiopathic arthritis. In children, band-shaped keratopathy may be presenting sign of chronic uveitis as a result of juvenile idiopathic arthritis. Now other causes include ocular causes of band-shaped keratopathy. Calcium deposit can include chronic iridocyclitis in adults. Then children with Still's disease, phthisis bulbi, chronic glaucoma, then chronic interstitial keratitis, ocular trauma and aphakia. Metabolic disorders, these are the ocular causes. Now coming to metabolic disorders, it is secondary to increased elevated serum calcium and phosphate. Causes include sarcoidosis, vitamin D toxicity, hyperparathyroidism, chronic renal failure and metastatic bone diseases. Okay. Now treatment, these are the causes. Now treatment, coming to treatment, it can be the corneal epithelium, chelation can be done. Here the corneal epithelium is scraped under LA. Under LA the epithelium is scraped, corneal epithelium is scraped. Then ethylene diamine tetraacetate EDTA solution is applied. That is chelation. Next is phototherapeutic keratectomy can also be done. Now coming to corneal dystrophies. Corneal dystrophies are inborn disorders, inherited disorders in which the cells have some inborn defect resulting in development of corneal haze in otherwise normal eye. There is no inflammation, no vascularization, no associated systemic disease. It is usually bilateral and usually manifest in first or second decade. This is the differentiating feature between corneal dystrophies and degenerations. Now coming to corneal stromal dystrophies. It can be granular, lattice and macula. Granular type and lattice type is autosomal recessive, whereas macular is granular and lattice is autosomal dominant, whereas macular is autosomal recessive. This lattice presents by second or third decade and macular by first or second. Because it is autosomal recessive, it is more severe and appears more earlier, so it appears by first to second decade, whereas granular appears by fourth to fifth decade. Now corneal erosions are frequent. Corneal erosions are frequent in lattice type. Okay, corneal erosions are frequent in lattice. Now opacities here in granular, there are discrete these sharp borders. With intervening stroma is clear early, but can become earlier. This in the early stages this intervening stroma is clear, but later on it can become hazy, and there is this clear limbal zone between the lesion and this limbal. There is a clear zone. Sharp borders, sharp discrete borders with intervening clear space. Intervening clear space and limbal clear zone, that is granular. Now coming to next one, lattice. Here there are early refractile lines like this. These refractile lines, these refractile tiny crisscross lines and subepithelial spots, diffuse central haze can be seen. These are lattice. The early crisscross refractile tiny lines can be seen. And macular, here there is indistinct margin. This is macular, indistinct margins and hazy intervening stroma. In between the lesion, the stroma is hazy, unlike granular, that is macular. Okay, it extends to limbus and the endothelium is affected. This is indistinct margin and hazy intervening stroma in macular. Now the normal, the thickness, the corneal thickness is normal. Corneal thickness is normal in granular and lattice, whereas it is thinned out in macular. In granular, the material accumulated is hyaline and the stain uses Mason's trichrome. In lattice, the material accumulated is amyloid and the stain uses Congo-red. In macular, the material accumulated is mucopolysaccharide and the stain used is Alcian blue. So this mnemonic, that famous mnemonic, Marilyn Monroe always gets her men in a city. This can be used. This men in LA city. That is macular, mucopolysaccharide, Alcian blue, then granular, hyaline, Mason's trichrome, and lattice, amyloid, that is amyloid, Congo-red. This mnemonic can be used to remember this. Then it is hereditary. Corneal dystrophies are hereditary, bilaterally progressive, not associated with local or systemic disease. This is the for corneal degeneration is the exact opposite. Okay, this is why this is important. This is the differentiating between this is the differentiating factor between corneal degenerations and dystrophies. Now few more extra things about corneal dystrophy. More about corneal dystrophies. Most common anterior corneal dystrophy is epithelial basement membrane dystrophy. That is anterior epithelium, no? So epithelial basement dystrophy. There is map or dot finger like this is a map or dot finger like dystrophy. Fingerprint like dystrophy. Then most common stromal corneal dystrophy is lattice type 1 is most common. Least common is macular. Autosomal recessive macular is least common. That is the least common. Okay. Most common posterior or endothelial corneal dystrophy is Fuchs endothelial dystrophy. Dystrophies affecting Bowman's membrane are the Rees-Buckler, Thiel-Behnke and Grayson-Wilbrand dystrophies. Those are the dystrophies affecting Bowman's membrane. Next, all corneal dystrophies are autosomal dominant except autosomal recessive is congenital hereditary endothelial dystrophy type 2. Okay, then gelatinous drop-like dystrophy, macular, we already discussed it, autosomal recessive. X-linked dominant is leash epithelial dystrophy, epithelial corneal dystrophy, and X-linked endothelial corneal dystrophy. Now this Rees-Buckler corneal dystrophy has the specific fishnet pattern of corneal. This specific fishnet pattern is seen in Rees-Buckler dystrophy. Rees-Buckler fishnet pattern of corneal subepithelial opacities. This fishnet pattern is characteristic of Rees-Buckler. Next, coming to ectatic conditions of cornea. Now, ectatic conditions of cornea. First, we will discuss about keratoconus. Now, it is a conical cornea, also known as conical cornea. There is progressive steepening. Progressive steepening most typically inferior to the center of the cornea. Most typically it is inferior to the center of the cornea, that is keratoconus. It is a non-inflammatory bilateral ectatic condition of the cornea, usually starts at puberty and progresses slowly it progresses. The patient will complain of progressive myopia and regular or irregular astigmatism. It does not, the most typical complaint is it does not improve fully despite full correction with glasses. Now it is eye rubbing is strongly associated with development of keratoconus. Okay. Then the cytokines interleukin 1 has been suggested a mediator of eye rubbing and stromal degradation. Now signs in keratoconus, first is Munson sign, that is the lower bulging of the lower lid on down gaze, that is Munson sign. Here we can see the bulging of lower lid on down gaze, that is Munson sign. Next is Ricciuti sign. Ricciuti sign is focusing when we focusing of a light beam shown on temporally across the cornea in an arrowhead pattern at the nasal limbus. When the torchlight focus using torchlight, if you focus a light beam, when it is shown from temporally across the cornea, arrowhead pattern is formed at the nasal limbus because of the steepening. Then the window reflex, that is a reflex is distorted, window reflex is seen. Then Placido disc, using Placido disc will give irregular circles. Here we can see the mice are closely packed below, indicating the steepening of cornea below. Okay, this is a Placido, this is a normal Placido disc. We can see the circular concentric circles. Here we can see the inferiorly it is tightly packed. That is seen in case of keratoconus. That steepening will cause irregular circles. Placido disc, irregular circles. Then corneal topography, for diagnosis in early stages of the disease, it is not visible clinically. Here we can make use of corneal topography. Then photokeratoscopy, there will be distortion of circles. Now on slit lamp examination, the hallmark is thinning and ectasia of central cornea. Now central cornea can be seen. There is something known as Flecher's ring. It is at the base of cone due to iron deposition at the base of cone. Okay. This is known as Flecher's ring. Here in fluorescent staining, it is visible at the base of the cone, there is iron deposition. Here again there is iron deposition at the base of the cone here. Okay. Now folds in Descemet's and Bowman's membrane can be seen. There is known as this Vogt's line, that is deep stromal striae. These are vertical striae. These deep stromal vertical striae is seen, that is known as Vogt's striae, which disappear with external pressure. In retinoscopy, there is yawning reflex or scissoring reflex. This is a scissoring reflex in retinoscopy. See, in normal case scenario, with the movement is hyperopia and off axis against the movement is astigmatism. This is against the movement. There will be, due to astigmatism, there will be both with the movement and against the movement, so it will appear as a cross reflex. That is known as scissoring reflex, which is seen in retinoscopy. Now on distant direct ophthalmoscopy. There is oil droplet reflex of Charlotte's. Here this is a dark reflex in the area of the cone. On observation of the cornea with the pupil dilated can be seen. That is oil droplet reflex. Then complication include acute hydrops, that is due to rupture of Descemet's membrane, especially in Down syndrome it is seen. Okay, this is acute hydrops here due to rupture of Descemet's membrane. It is usually more common in Down syndrome. Management, in early cases we can use spectacles, rigid gas permeable contact lenses, and intacs. Intacs are intracorneal ring segments, and corneal collagen cross-linking can also be done with riboflavin. Riboflavin, that is vitamin B2. Riboflavin can be done. It slows the progression of the disease. Late stages we can do deep anterior lamellar keratoplasty, penetrating keratoplasty. Next is corneal opacity. It can be nebular. Nebular is, it involves only the Bowman's layer and superficial layer of stroma. Superficial layer of stroma and Bowman's membrane, that is nebular. Now macular opacity, it involves up to half of corneal stroma. That is macular. It involves up to half of corneal stroma. Leukomatous scarring of more than half of stroma is involved. Elderly glaucoma is when healing occurs after perforation of cornea with incarceration of iris. Corneal facet is corneal surface depressed at the site of healing. At the site of healing, the corneal surface is depressed, that is corneal facet. Keratoplasia, it is corneal curvature increased at site of opacity. Corneal curvature is increased at site of opacity. Keratoplasia, corneal curvature increased at the site of opacity. Now coming to treatment, optical iridectomy in central corneal opacities can be done. It is usually done in central corneal opacities. Provided vision improves with pupillary dilatation, and phototherapeutic keratotomy and tattooing of scar can be done. Now corneal vascularization, it can be superficial vascularization or deep corneal vascularization. Superficial vascularization, the vessels arranged in arborizing pattern. And deep corneal vascularization, the vessels are straight and not anastomosing. Here the vessel is present below the epithelial layer, and continuity can be traced with conjunctival vessels. Okay, below the epithelial vessels, it is present below the epithelial layers, and continuity can be traced along with conjunctival vessels. Here the vessel is present in the stroma. It is derived from anterior ciliary vessels. And continuity cannot be traced beyond limbus. Here the continuity cannot be traced beyond limbus. The corneal superficial vascularization is usually seen in case of trachoma, flectin, rosacea, keratitis, superficial corneal ulcer. Deep corneal vascularization is seen in case of interstitial keratitis, deep corneal ulcer, chemical burns, sclerosing keratitis, and after keratoplasty. Now coming to certain pigment deposition in cornea. Now iron pigment deposition, in keratoconus it is known as Fleischer's ring. Old opacity, it is known as Hudson-Stahl line. Pterygium, Stocker's line. Filtering bleb, Ferries. Then siderosis, also there is iron deposition. Blood staining of cornea, also there is iron deposition. These things you should remember. Keratoconus, then it is known as Fleischer's ring. Old opacity, Hudson-Stahl line. Pterygium, Stocker's line. Filtering bleb known as Ferries line. Copper deposition, it is seen in Wilson's disease and chalcosis. There is characteristically this case of KF ring, that is case of Fleischer. So Fleischer's ring is seen. Here the location is epithelium. Okay. In siderosis, it is mainly stroma, and blood staining also it is mainly stroma. Then in copper, it is Descemet's membrane. Now melanin deposition is seen in pigment dispersion syndrome, that is known as Kuchenberg spindle. It is seen in endothelium. These few things you should remember, that is pigment deposition. Next is enlarged corneal nerves. Local causes can be due to keratoconus, keratitis. It is most commonly seen in acanthamoeba keratitis, most characteristic of acanthamoeba keratitis. Okay. Then Fuchs, endothelial dystrophy, trauma, congenital glaucoma are the local causes for enlarged corneal nerves. Now coming to systemic causes of enlarged corneal nerves, meant to be neurofibromatosis, Refsum's disease. Now, keratoplasty. The keratoplasty is corneal grafting or corneal transplantation. Donor cornea taken from cadaver within 6 hours after death. Within 6 hours. Short-term storage is that is up to 48 hours. Where globe is stored in 4 degrees Celsius moist chamber. Or there is intermediate storage up to 2 weeks. It is known as MK medium. That is McCary, Kaufman medium. Or long-term preservation is there, that is up to 35 days. It is organ method or cryopreservation at minus 70 degrees Celsius. Cryopreservation or organ culture method. Coming to complications of keratoplasty, early complications include flat anterior chamber, iris prolapse, infection, secondary glaucoma, epithelial defects and primary graft failure. Late complications include graft rejection. Graft rejection, here endothelium is the main target. Okay, major target is graft rejection. Late complication is graft rejection. Here endothelium is the major target. Endothelium. Recurrence of the disease can occur in case of dystrophies and all, and astigmatism can be there. Now, contraindications of graft rejections include Creutzfeldt-Jakob disease, subacute sclerosing panencephalitis, rubella, rabies, HIV, hepatitis, syphilis, retinoblastoma. Now, in graft rejection, the subepithelial infiltrates are known as case dots. Then there is stromal rejection. In stromal rejection, there is sudden onset of full thickness stromal base. In endothelial rejection, there is something called Cordellus line demarcating the healthy. This is a Cordellus line. Here, line demarcating the healthy and damaged cornea. Then subepithelial infiltrates known as a, here you can see subepithelial infiltrates known as a case dots. That is seen in keratoplasty. In graft rejection in keratoplasty. Next we will discuss about refractive procedures a little bit. First is LASIK. LASIK full form is laser in situ keratomyelitis. Here we make a epithelial flap with a microkeratome. This is a microkeratome here. Epithelial flap is made here. Where then we selectively ablate the corneal stroma with excimer laser 193 nanometer laser, and we replace the flap and no sutures, it sticks by itself. That is LASIK. Here we make a flap with microkeratome, make epithelial flap with microkeratome and selectively ablate corneal stroma with excimer laser 193 nanometer, then replace flap, no sutures, it will stick by itself. It is less painful. Since there are no sutures, it is less painful, faster visual rehabilitation, but it is not suitable for thin corneas. Side effect is, later on we can see this diffuse lamellar keratitis. Here diffuse lamellar keratitis can be seen. It is known as Sands of Sahara syndrome. That is LASIK. Now coming to LASIK, that is laser subepithelial keratomyelitis. LASIK. Here we remove the epithelium as a sheet with 20% alcohol. Here in LASIK we used a microkeratome. Here we remove the epithelium with 20% alcohol, and then we'll ablate the stroma with excimer laser, same, and replace epithelium. And insert bandage contact lens, followed by we'll give a bandage contact lens. It is useful in thin corneas. Here microkeratome is not used. Here 20% alcohol is used. Remove epithelium with 20% alcohol. Okay, it is useful in thin corneas. In epi-LASIK, here we remove epithelial sheet with epikeratome and ablate stroma with excimer laser. Here instead of microkeratome, we use a epikeratome to remove the epithelial sheet and then ablate stroma with excimer laser, then replace epithelium and followed by bandage contact lens. This is also useful in thin corneas. Next is femtosecond laser assisted LASIK, that is wavelength. Femtosecond laser 1053 nanometer is used to create flap. This is used and not blade in femtosecond laser. hence it is known as bladeless LASIK. Okay, that is femtosecond LASIK, femtosecond laser assisted LASIK. Next is photorefractive keratectomy. Here we remove epithelium using blade, spatula, burr, diamond knife, laser or alcohol, and then selectively ablate cornea stroma with corneal stroma with excimer laser. Here we remove the epithelium with this diamond knife or burr, and then we selectively ablate the cornea with excimer laser and insert BCL. After excimer laser, we selectively ablate the cornea, then insert BCL. Advantage of over LASIK is there is no issue of flap related complication, especially in case for military contact sports etc. Then in disadvantages is post-op pain and slow recovery. Next is thermokeratoplasty, also known as conductive keratoplasty. Here local heat induced shrinkage of corneal tissue. This will lead to corneal steepening. Holmium laser is used to treat, it is used to treat mild degrees of hypermetropia and presbyopia. Next is SMILE, that is small incision lenticular excision. Here small incision lenticular excision, here femtosecond laser is used. And no flap is created. Using the laser we take a small amount of lenticule from the stroma and then we change the refractive error. That is about refractive procedures.